you would see as these people joining as very rude, very, untamed, but that's actually their culture, and they are communicating in the best way that they would have communicated in the most respectful way.
My name is Dr Najeeb Rahman. I'm an emergency medicine consultant in the NHS, as well as a senior medical educator with MPS. I've been fortunate that throughout my career, I've had the opportunity to work in a variety of roles in a range of international settings as an emergency specialist, as well as a humanitarian practitioner in clinical and managerial capacities. What has often been so critical in those experiences, and in particular their translation back to daily practice, is the role of teamwork. In today's episode, we're going to take some time to reflect on our experiences as a diverse group of health workers delivering care to diverse communities. There is a Rwandan proverb which states, "People helping one another can bring an elephant into the house," epitomizing the power of teamwork in overcoming challenges. However, many of us will be familiar with the phrase, "the elephant in the room," in its relation to an important issue which is obvious, but no one wishes to discuss. Tackling the challenge of our own cultural experiences and how that may impact our care approaches in the delivery of high quality and safe healthcare is one that is complex. Perhaps we can make a start in moving this proverbial elephant together. Joining me today to explore these concepts further is Dr. Gabin Banjamucho. Dr. Gabin is an emergency medicine specialist who trained in Rwanda and is currently working in one of the busiest emergency departments in the UK. He is a researcher and an expert in point-of-care ultrasound, particularly as a decision support tool in resource-limited settings. Welcome, Gabin.
Thank you, Najeeb.
Thanks again for taking time out to take a deeper conversation on some of the challenges around working in the NHS as an international medical graduate. I feel it would be really helpful to understand a bit more about the environment in which you worked in before coming to the UK. Can you describe the department and hospital you worked in?
Before coming to the UK, I was working at Kigali University Teaching Hospital, which is popularly known locally as CHIK. This is the major trauma hospital and major referral hospital in the country. They receive about 40 patients per day, compared to the UK, where you receive about 400 patients for 24 hours. At Kigali University Hospital, these are high severity patients being referred from other hospitals. So coming to the major trauma center, which was CHIK, most of the patients had to come from another hospital, or they were brought in by the local ambulances, popularly known as SAMU, being a referral. Maybe they might be a trauma, or they might have come from home, but the ambulance would have triaged them as to be high acuity.
So essentially, this is like having 40 critical care resuscitation cases coming in every 24 hours with significant injuries, significant septic illness, so on and so forth.
Okay, that's correct. So you would really have basically like 40 resusc patients admissions per day, compared to the UK, where you have 400, and the people who are really sick would be around 20 or 30 very sick, and the rest, maybe 200, would go home. The other about 100 might be observed or sent home. So that's how it compares. This would, in general, drain the resources and the human resource as well present in the hospital. Staffing wise, from 2018, there were staffing by entirely locals, but before that, the attending, that's a faculty staffing there, were visiting faculty from the UK, from the US, and sometimes from Canada, who are training local emergency medicine doctors to become emergency medicine consultants. We had also other people in terms of surgeons, other specialties, surgery. There's major specialties. Maybe there's lack of subspecialties. You will not get things like vascular, plastics. There was 1 or 2 plastic surgeons. Cardiology, in the whole country, there are less than 10 by now. By that time, you would have 1 or 2 cardiologists in the whole country. So there was a lack of subspecialty, but general specialties, medicine, gynecology, surgeons, orthopedics, those were they were present at that time. We had nurses who are locally trained. Now, at that time, also there were subspecialties which started to train in nursing.
Now, you mentioned a little bit about resource constraint, and okay, so we've got some challenges in terms of senior workforce specialization, but I presume that skill mix also filter down into nursing tiers as well, right?
Yeah.
And in terms of access to treatments and investigations, was this free at the point of care for your patients in Rwanda, or was there insurance places, or was this out-of-pocket expenses?
Yeah. So what happens in Rwanda, by law, what happens is if a patient comes to A&E, by law, they have access to 24-hour free of charge care in A&E. And anything else after that, they would have to pay for that. That was what was the hospital, and that was by law. But in general, what happened is if patients were able to pay, they would have to pay 10%. And the equipment and medication available, which was accessible to 10%, was only the medication that was provided in hospitals. So if you went outside the hospital and you had the general, which was the public insurance, you would not buy medication on 10%. So you would have to pay 100%, unless you had private insurance, which would cover also other private pharmacies. So in hospital, only care in hospital and medication in hospital, you had to pay 10%. But 10% for someone who had a job, that's probably affordable. But if someone didn't have a job or they were rural-based, depending on farming for a living, that would be something very significant, which would not be affordable to quite a number of people.
So that's really interesting. And I think perhaps within the UK, we probably don't understand or appreciate so much the complexity of healthcare financing in other settings. I think a lot of our listeners who have trained and worked abroad will appreciate some of that complexity. But in general, then, from a perspective of health practice and health culture, how are decisions made by health professionals and a team? And additionally, how do you engage with patients and care plans within that context?
Reflecting that, probably this would be my opinion on what I feel, and maybe a few people might disagree on that. But looking on how decisions are made professionally, it would be on an individual basis. So looking at how patient care is not standardized, there was no general, let's say, guidelines. While when you look at the UK, how things are, it's trust guidelines have to be mostly referred to almost in all cases. But looking at how things were in Sershka, that would be depending on an individual basis, on their training, their knowledge. So we'd find different care on the actually similar patients, depending on who are caring for them, which would generally impact the long-term outcome of the patient. That not having a standardized care. That means if the patient at some point had to go to another hospital, they would get a little bit different treatment. And also considering that in Rwanda at that time, people trained in different backgrounds. There are people trained in Europe, Belgium, France, the EU, some were trained by Americans, some trained by South Africans, some places in West Africa. So everyone had different ways of approaching a patient. And depending on what you are reading also, that if you are reading American guidelines or you are reading South African guidelines, that was totally different. So there was a little bit different on our approach. In terms of engaging with patient, of course, culturally that it plays in culture also on your training. The general perception is the doctor is always right, and most patients would accept what the doctor tells them to do. In terms of, for people who had high education, maybe exposure and large families, sometimes they would have to engage with a doctor, or if they're going for private treatment, they would more or less engage with a doctor. But in public sectors, it's very rare that you would see patients being included in their decision makings? What's the final outcome? And the general perception is people are generally, they just go with what your superior will tell you in general. So people are quite obedient.
So quite hierarchical in the decision making. And despite having such a diverse group of practitioners from training backgrounds, I guess the teams are quite different in how they communicate and work together with, I guess, slotting into expected roles where it may be very difficult to challenge those hierarchies.
That's correct.
Okay, so thanks for sharing that. And the reason I wanted to unpick context a little bit is because, with a diverse workforce, a lot of us have different backgrounds. And, clearly you were pretty senior and a skilled practitioner, but how prepared did you feel for then working in the NHS? So understanding that complexity, that background of where you came from, your seniority, what was it like then coming to work for the NHS?
Coming to the NHS at the beginning, to be honest, I was not really prepared to come to the NHS. If you asked me 2 years before I joined the NHS, I had no idea that I was coming to NHS. It was just a talk with 1 or 2 people, and then things were not going how I wanted them to go. When I was in Rwanda, I felt that there was still room for me to grow, and where I was, I don't think I was going to achieve my goals being there. So I tried to explore the NHS. That's how I came here. Coming here, basically when I was in Rwanda, I was pretty senior. But joining the NHS, I found it initially to be quite different. And now I'm starting to see it when I do help doctors who are doing their OSCE exams for their MRChem OSCEs. A few of them are international, and now that's where I'm starting to understand what was happening. So when you're practicing in limited resource, particularly in Rwanda where I practice, you go by mostly small practice, procedure-based and knowledge-based. So you go, you read, this is how we treat, let's say this is how we treat a wound, and the empathy, the guidelines, safety checks are not really that much included when, rather than we look at the outcome, rather than how we achieved the process. So while treating in the UK and probably in a high-income country, there is things like empathy. It doesn't matter your knowledge. Your knowledge is not really the most important thing. Is how do you approach a patient? How do you offer coffee? I was told you have to offer tea to patients, which I never did before. So you approach patients. You had to, approach them, talk to them, get history from them, have an empathy way while not patronizing. While you get used in other places, nobody is going to counteract what you're saying. Here, patient can easily challenge you. So these are skills that unfortunately I was not ready for. Managerial roles, also managerial way. Having a senior role in Rwanda and coming here, I was pretty also started on a senior role. The managerial way of approaching different things, like some mental health patients, those are things that we don't really get taught in a limited resource. Mental health approach to patients in mental health, that's not part of our curriculum. You deal with them on basis of on our basis of your knowledge. Today, how I deal with them is different from what you deal with them. Domestic violence, also, these are things that you tend not to be, it's not part of your curriculum to cover, and you tend to manage on a personal basis. Patients intoxicated, that was something not spoken of compared to coming to London where you have quite a lot of intoxication drugs. These are things that I was not really ready for. And unfortunately, coming to a senior role, those are things that you have to really get involved. While though I was very comfortable with procedures, it's less likely that you do procedures because you have a lot of subspecialties who can come and help you. So you needed to learn the emergency department safely, make sure that patients are seen on time, and engage with nurses, while nurses also here have quite a a higher role, and they are quite senior, so they make decisions. Unlike where I came from, where nurses really have to wait for what the doctor has to say, here it was you're on the same kind of level basis. So those are some of the things that, of course, over time I've come to learn, which I was not prepared with, and I didn't have.
So theoretically, on paper, two senior emergency physicians, one trained in the UK, one trained not in the UK, but actually quite a big differentiation in the context in which you're working, but also in terms of that role, right, between technical versus non-technical skill sets, and how do you start to match that? So I guess there's two questions that come to mind. One is, the practical issues of coming to the UK from Rwanda. What was that orientation and induction like? And, if you were to kind of speak to yourself again, looking back, would you advise your new self something differently about getting used, whether about the GMC or HR processes, this is the basics of getting food and housing and stuff like that, versus actually then getting used to a system as well. So I guess let's go by this layer by layer. What was it like actually moving and transitioning to living in the UK, and then also transitioning and living as part of your new role?
Moving and living in the UK, definitely that was really hard. Especially I came when winter had started. I remember I had to buy a very expensive jacket. I still have it. I had my home clothes. That was quite something. It was very warm for me when I was in Kigali. That was the warmest coat I had. But landing in the UK during winter, that was nothing. It's just like I was very naked. So that was the part of the difficult part. And I realized also London is quite a big place. While we get used to in Rwanda, it's a small place, and you would ask someone where everything is, so everyone would know that's where it is. I found it a little bit difficult to get around. So
it's quite disorientating, probably.
Nobody knows. You ask someone where is the market, nobody knows. Just follow Google Maps. So I had to learn how to use Google Maps, and moving in. Of course, the good thing is London is quite multicultural. So food-wise, after I got to know 1-2 people, they oriented me to get what I got used to. And after some time, eventually you get used to what everybody eats, because this is a multicultural. Eventually, if you're going to stay here, then you have to learn. If you're moving to Rome, you have to learn how to live like the Romans. That's the saying that is quite people use. Then setting in, of course, on a personal base, you have to learn. Always where you work at King's is a multicultural. There's always a new doctor. There's someone who has gone through the same struggles, and they tell you things, and you learn from them. And also having the.
But that was all informal, right? Yes. This is not formalized as part of an induction process. You had to kind of navigate your way around. Yeah. So I guess perhaps if those skill sets, so of someone like yourself, and maybe a few other colleagues, if you came together to form a bit of a group to support new doctors coming in, do you think that's kind of a solution to make the landing a little bit easier and a little bit smoother?
So yes and no. I would say, or I will start on the yes and no. Definitely yes, in the general thing. But let's go back to how forming these groups would be. So looking at most doctors who join the NHS, these are people from mostly Asian and Middle East. These people know about the NHS since they joined medical school. I had no idea that there was anything called the NHS till 2018, 1 year before I joined. I think when I started getting the papers, I had to read what does NHS stand for. So I had no idea what NHS is. So these people they have everything. People have, my colleagues who are on the same level had already covered MRChem. They had literally knew everything, things that even now I don't really know. So having a group definitely is very important, but they had to be brought down to also where you're coming from and what do you know about the NHS, if that makes sense.
Yeah. So they have to be able to span and maybe not make assumptions on what new colleagues may or may not be aware of. So I think a lot of this is, again, I guess, linked to assumptions of people's experience and background, and expecting a new doctor to have already hit the ground running, when actually, from what you've described, is that appreciation of a bit of context and baseline understanding and aspirations is probably important.
Definitely, the way you would orient someone who's coming from India, maybe I would say, is not the same way you would orient someone who's coming from an African setting. The culture is different, the understanding is different, the practice is different. Some countries, they just do UK exams and that's it. That's the same. They do the same.
But that's not the same. That's not the same as living and working in the UK, even if you
exactly.
Exams, right?
So definitely you need to help people. Like the induction I got is, okay, there's a computer system, that's EPR. I got 1 hour of EPR. That's the first time I had written anything.
Electronic patient records.
So these things, and it's assumed, okay, you're coming to NHS, you assume to have read about the NHS, you're joining a job. So a few hours of induction, that was it. And then that's it. The rest I had to run as I'm going.
So I think this is really, really helpful, Gavin. So, we recognize that delivering modern healthcare is clearly heavily reliant on non-technical skills. You described this difference between your background, which was very technical focused, and actually transition to the UK, which is, modern healthcare, very non-technical skill reliant, and we appreciate that. And this includes cognitive and social abilities such as risk perception, situational awareness, decision-making, teamwork, leadership. So if we can acknowledge that such elements are strongly influenced by language and culture, are there examples where, for example, in complex cases such as airway intubation in a critical case, where these non-technical cultural issues were markedly different between Rwanda and here?
Definitely huge difference. And unless you have worked in both environments, probably you might not understand. So let's talk about maybe, as you said, airway or complex situations. I would give an example of I had a patient who I was going to put a central line, and the patient became unstable and progressing it on the monitor. I had to act fast. So I a little bit raised my voice, which was very normal for me. Fine, everything went well. Nothing came to harm. We recognized the harm, but eventually I got a feedback that was quite very rude. So, to the approach, which I was like surprised. But looking at things and which some things I learned, like saying please. To be honest, there's no word in Rwanda that says please. If Rwandans might disagree with me, but it's not something that we do say as part of. It's not part of the language.
It's not really something that's.
You don't ask, can you give me a glass of water, please? That is just give me a glass of water. That's a language. There is no please behind that, unless you're speaking, you're adding an English word or a French word. So there's a way you can phrase that to look polite, but these are things. The language is based and the culture is based on telling people to do things, communication. Thank you. People use thank you now, but it's not something historical or part of culture in Rwanda.
No, it's There's just part of an expectation of how people go about their lives. So transposing that here, where actually please and thank you are quintessentially British.
Yes. So these are things that probably, and my first language is not English. English is my fourth language. So if I didn't grow up speaking English, that would be totally seen, you would see as these people joining as very rude, very, untamed, but that's actually their culture, and they are communicating in the best way that they would have communicated in the most respectful way as to another patient in their country. So in their country, they don't look rude. There's no way I look rude, but these are things that are totally different, and you learn as you do stay here for some time.
So I guess, you've adapted a little bit to that environment, which, I guess makes sense when you're looking after patients who fit that same cultural mold. But from the perspective of your, I guess, colleagues who are, homegrown, for want of a better phrase, or, is there anything that they could have done to understand? So, when you went through that complaint, were you understood? Was your perspective valued to say, look, this is just quite alien for me to do this? Or was there an expectation for you just to start modifying your approach from the start?
To be honest, I don't, let's say on that particular case, I just was receptive. I said, yes, I'm so sorry for this, I'm trying to learn, and hopefully next time to be better. Because there was no way someone who has not had different cultural exposure could understand how you could not say things like, please, could I get, and you just say, get me, please, go, give me that one, give me this certain, give me oxygen, for example, rather than, could you please give me oxygen? Could you please get me a mask? In general, you are saying the same thing, but you are using different words, and to be in either way, in back of my mind, to be honest, it's the same,
But it took some time to adjust, I guess, and maybe that could have been, that kind of insight might have been helpful.
Yeah,
starting off from the beginning.
Yeah. So during that time, I've developed over time friendship with quite a lot of my colleagues, and I become open to them, and I tell them, you know what, I have a different culture. I'm trying to be the best I can. So let me know when I go wrong. When I say something that you don't like, let me know so that I can change, because I'm trying to adapt, Some, of course, they knew every time we have new people, of course, they say always we go back to zero. But with people who I'm used to, they sometimes, once you're in a stressed environment, they wouldn't understand, Once I'm in a stressed environment, of course, they please and thank you, go away, and I go back to my normal self. Yeah.
You revert back to your roots. So this is really interesting, though, Gavin, because I think there's two things I'd just like to explore a bit further based on what you just said. One is that, you've invited people to check you, to have your back, because you've recognized and developed insight that we work as a team. Teams need to be able to speak up to be psychologically safe to raise their concerns. And you've gone out of your way to try and make sure that people recognize that you're happy to be checked. But then this goes back to this journey, right? So have there been times when people maybe have had concerns about your performance, and have they chosen to raise this with you directly in the moment, or have they decided to go in a more formal way and almost kind of report to you rather than trying to address this in the moment? Have you had those two experiences?
Definitely, yes. Literally, I have had lots of complaints about me, but unfortunately, no complaints has been raised to me, directed to me. So, I have learned through the system. Initially, what I learned about joining the UK, I think it's mostly the UK system, is people will almost always avoid direct confrontation with someone. I mean, it seems like giving feedback is done by probably your supervisor rather than by someone you just had, you have had a confrontation with. In terms of clinical issues, clinical scenarios, quite a lot of them have been sent to my supervisor, who is quite friendly, to be honest. He has been very, very helpful, and he understands the culture. He understands almost everything we have had. We have become so close to each other that I know his family. I go to visit him and his child, sometimes spend time with him. So we have become so close together that he tells me, he guided me. So there's a few cases. I can give you hundreds, to be honest, like a few dozen. But just to choose on, let's say there's in one case scenario that when we are doing a procedure, I was doing the procedure and someone else was doing was giving medication, and it ended up being that the medication given on the higher side, nothing can harm to a patient, but to go through that, I mean, they had to be so many people called, a lot of processes, but I was not. At some point, someone thought I was the one, and it was reported, and you get reported to some behind. But when you eventually it turns out to be you, it doesn't get reported. So there's that kind of bias that I went through, and also the other things that you're working with colleagues, and you ended up by everybody's smiling at you saying thank you and how you did great, but the next day you find that you have an email about the situation. I'm like, oh, we were chatting, they got me coffee, during the shift, and nobody told me anything. It's not, I think it's a UK culture that people don't want to get into conflicts. They don't want to give direct feedback to what has happened. Unfortunately, when the information goes, it goes to someone else who passes it to your supervisor. So the information has become totally inaccurate. And by that time it comes back, it's 1 or 2 weeks, and you can't even recall exactly the situation. And that doesn't really help, especially people who just go to the UK, who moved to the NHS. It doesn't really help them grow. So you are in the same situation because the case comes to you, it's diluted or it's totally different. And no, I didn't do this. I never meant this. And you are being given because it's been reported, it goes through a committee that sends to your supervisor. Supervisor hears it differently. You end up getting told the wrong information for the wrong thing. While these things were not really, most of these things, patients didn't come to harm, It's not a serious. If patient came to harm, definitely that should be reported. But these are things that could have sorted there and then, and someone is smiling at you, telling you how great you are. You're working together 1, 2, 3 days, they're getting you coffee, but after 2 weeks, you're like, oh, we need by your supervisor, what did you do on this day,
So this is really interesting, there's so much to unpack from that narrative. I guess one, it shows how important it is to have a supportive mentor and supervisor. And I guess not all of us have that experience. We've had ranges of supervisors and mentors, and if someone doesn't get that context, then that itself would be a barrier. I mean, we recognize already when we look at GMC data that if you are from an ethnic minority, you have an increase in referrals to the GMC. And if you're an international medical graduate compared to the local homegrown graduate, it's almost 3 times as much, I think, the referral rates to the GMC by your own employer. So what you've described is very real in terms of this kind of reporting culture. But what's interesting here is that there seems to be an element where people really struggle to speak in the moment and try to clarify assumptions and clarify misunderstandings there and then. So it ends up becoming a more formalized process. And then also, as you said, it really impacts your own personal and professional development, because the context is sometimes lost when it's been filtered through these different referral tiers. So what does that do for you, in terms of building trust with your team? I mean, I presume it's been far more difficult to then build that collegiality, right?
Yeah. Eventually, it downgrades your morale, your participation in a group, you being part of a group, and your development as well. So eventually it does that. But the good thing is where I work at King's is quite multicultural, and we do have very senior consultants who have been there who do understand these things. And some of our colleagues also do understand these things, and they do know that this happens. And they have started speaking it openly, they have started talking about this bias, and unfortunately, sometimes you do see there's a colleague, to be honest, who has gone through a lot of trouble. For me, coming from a background and African settings, I understand him. Fine, I do. When he always got in trouble, he talked to me, I talked through him. I could understand him, though I'm like, you know what, you have to learn. You came to UK. If you want to be here, you have to learn the UK way. That's the easiest way.
Yeah, there's something about adapting and understanding local culture and context, but there's also, I guess, a challenge for us, who are established in this, is how do we make that translation and transformation easier for colleagues coming from diverse backgrounds? Because again, we are serving diverse patient communities. And so I'm sure making that transition to the UK practice, if we could accelerate that without increasing the burden of harm to well-being and resilience, I think that surely is not a bad thing, right?
Yeah.
If we could have made that transition easier.
Definitely. They need to be a way to tackle and help these people with transitioning. Considering that most of the people who join the UK and what they do, they mean really well.
Yeah, no one comes here to do a bad job, right?
So, yeah, no, nobody comes to do a bad job. And they are really helping the system as well. They are needed. It's not that they are burden to the system. These are people who are contributing to, the care of the UK and everyone. But having them, they need to be a pathway in terms of them being understood. And unfortunately, in some cases, that's not the case. There's been a lot of campaigns. There's been a lot of, groups going out there, media, emails about, these biases. But I don't see it really improving. There is no...
Hasn't filtered down yet onto the front line. Yeah.
And unfortunately, it's not... Sometimes you might see it, sometimes it's these things are done by white people towards Black people. It's not the case. Sometimes it's Black British and or Black people who moved to the UK doing the same thing, and they come here and they totally don't understand other people. So it's not about color. It's about
culture.
Yeah,
it's about culture and attitude.
Yeah,
isn't it?
Exactly.
How we identify ourselves.
It's not. Yeah, it's not like it's a white man to no. It's even people who are Black British do that similarly to people who are moving here.
So actually, that links when we talk about culture. Then actually, that also links a little bit about power and actually power influence and how does those roles play out in the workplace. So one thing that I just wanted to touch upon as we start to wrap up is about global health. So one of the things I found in my experiences, as I said in the introduction, is working in diverse environments, and it's really helped to advance my own technical and non-technical skills and ideas around resilience and well-being. And you come across as someone who has really had a very reflective journey in the last few years, and have also been exposed to lots of other diverse colleagues when working in Rwanda, with visiting colleagues from the US and Canada and other countries. So how do you feel experiences working in a range of global health settings? How do you feel that's actually acknowledged and valued locally when dealing with diverse communities? And are there missed opportunities for strengthening our work here in the UK, using that global health lens?
Definitely working in different backgrounds definitely is I think is the best decision I ever took, because looking at the global health perspective is you tend to understand things, meeting people and also treating patients, after being in different settings and coming to the UK, you tend to find that even dealing with patients who are from different backgrounds, you see London, people are different from different backgrounds, you find that you're more comfortable with them, different, because you tend to understand them. Talking about, there are people who come from, whose culture is based on religion, and other people do. But once you work in different environments, you tend to respect them and you tend to understand them. Actually, if someone says this is what's going to happen, you tend to respect that because you understand from where you came from where you passed through, and you tend to deal with these patients, you understand them. Let's say if you trying to refer to this, you have
some commonality with those journeys.
Exactly.
And I guess you have a more broader view in terms of diversity and inclusion and checking one's biases, I guess.
Yeah. And coming to your other question about the UK, I do find that people in the UK don't explore to go outside and understand. You might find someone who went to Tanzania in a rural hospital somewhere, but it's not really integrating with the community and spending, some good time. It's just a controlled kind of environment. And I do think they do miss on the global opportunity of correctly understanding. UK as a country is a country that wants to deals with a lot of donations to poorer countries, and I think they would understand it more if they explored more about, this is a missed opportunity that's out there, and they would integrate much easier, and also, do whatever they want to do much easier if there was this kind of global understanding and intercultural integrity more.
Yeah, no, thank you. So Gavin, just before we finish, now I know something about you, and I know that you relish new experiences, whether it be skydiving or indeed diving with great white sharks. So I'm wondering if any of those other experiences outside the healthcare setting have had a meaningful impact on shaping your perspectives and how we adjust to this environment that we work in.
Yeah, definitely. I do say, yeah, I'm a clinician, but outside, I have an outside life, and I do like spending time with different people from different backgrounds. I just spent some time with a friend in Pakistan, for whose background is Pakistan, and it quite taught me a lot of things. So I do think meeting different people outside work, it's really satisfying, knowing that there is, it's not about the 1,000 hills in Kigali and the gorillas. There's other things that exist out there, and they're really satisfying. And you do find that people are happy in their own way. You think, okay, Rwanda is quite a very nice, beautiful country, but you do find, people are so happy in their own different ways and in their own region. You find that, yeah, I have my friend who is quite, my close friend is Muslim, and when he goes pray, sometimes, I'm just like, okay, fine, we were out, and then I'm going to pray, yeah, I will stay with your children, you just go and pray. These are satisfying things, and you tend to understand. So outside work, I mean, getting to know different cultures to me is very satisfying, and it has really helped me grow so much and understand, and get that happiness from doing that.
Fantastic, Gavin. Really good way to conclude. So I think, that's been a really interesting journey, Gavin, and thank you for spending the time to talk about not only the background of your experiences in Rwanda and how that shaped a little bit of who you were then, but also the challenges in transitioning to a very different healthcare environment. And from what sounds, at times maybe a bit of a rough landing, but perhaps that's something that many people experience, and talking through some of the ways that cultural adaptation might have been made a bit easier, when looking about feedback, when looking about, team dynamics and communications. I really valued the way you talked about the importance of being open to check one's own biases, but also to reach out and provide opportunities for learning for others. So thank you, Gavin, for this.
Yeah, thank you for your time, Najeeb. Thank you.
There was a lot to reflect upon in today's episode when considering the challenges of working in the NHS as doctors who have trained overseas. It's helpful to frame our thoughts in terms of the factors that impact our performance when it comes to transitioning to working in a new healthcare system. These factors can be experienced at interpersonal, organisational, or structural levels. As has been highlighted in today's podcast, as well as in literature and reports published on the issue, certain factors, such as avoiding difficult conversations, isolated or segregated working, or a blame rather than learning culture, can all increase the risk of disproportionate complaints and bias, whereas neutralising or protective factors in improving the transition of colleagues to maintain safe care include things like honest and direct feedback, role and team integration, cohesive and accessible leadership, and a wider strategy for inclusion. If you're a member of Medical Protection and you want to know more about today's topic, we strongly encourage you to check out our IMG Hub. Here you'll find more information and training that is specifically made for our UK IMG members. Links for these can be found in the podcast description. And with that, we reach the end of today's podcast episode, Moving the Elephant into the Room. If you're new to podcasts, maybe listening for the first time, make sure you subscribe to the channel to make listening in the future easier. You can access this podcast from all the major apps, including Apple and Google Podcasts and Spotify. For more information about Medical Protection, or if you're already a member and would like a certificate for listening today, please look for the details in the description. I've been your host, Dr Najeeb Rahman. Thanks for listening.